All right, so we're here to talk about surgical site infection surveillance, and just as the others have mentioned, what we want to discuss today is what's going to be new for 2013. So a lot of the stuff will be the same, but where there are new things, I have them highlighted for you in the slide set. So just again, where does this fit into the NHSN structure? It is one of four of the patient safety it fits in the patient safety component, which is one of four NHSN components, the long-term care component having just been activated in the last week or so. And, okay. Can you make it louder so they can hear me in the back, please? Thank you. Okay, is that better? Good, I felt like I was yelling, so now I won't have to yell. The procedure-associated module is in the patient safety component part of NHSN, and it currently only includes surgical site infection surveillance, it includes surgical site infection surveillance. In 2011 or 2013, we'll be getting rid of post-procedure pneumonia altogether. So at the end of this year, the post-procedure pneumonia part of the module or that event will be retired. So there'll only be SSI left. So some of the resources that you'll need to do SSI surveillance, as others have shown you, are the forms, of course. And for January 2013, we'll be updating the forms accordingly to what's required. So you'll need the monthly reporting plan, as you usually do, the surgical site infection form, and the denominator for procedure form. In addition, you'll need the patient safety component manual, and in the January 2013 edition, you'll want to look at Chapter 1, which has an overview of NHSN, and in that will be included some surveillance techniques. Chapter 3 has the reporting plan information in it, and there'll be a table of instructions for completing the reporting plan, which has not been available in the past. And then Chapter 9, which is where the protocol is currently, and we will be adding the forms and the tables of instructions to that chapter. So sort of a new format for the patient safety manual will be to have the protocol, the forms, and the tables all together in the one place for you. Chapter 16 still includes some key terms that you'll want to make reference to, and obviously you also need the infection site definitions, which will be in Chapter 17. Now, as has been mentioned by previous speakers, the surveillance plan or the reporting plan is our roadmap to your data. So when you put something in your plan, those are the only data that we look at and analyze at CDC, and they're the only ones that are usually shared with entities like CMS. And typically, they're the only ones used by state health departments, although that's not always true. So we refer to those kinds of information as in-plan data. You might hear us talk about in-plan data. It's anything that you've indicated in your plan. And the plans are also really important because they drive a lot of the business logic of the application. So a lot of times when you go to enter an event or a denominator record, behind the scenes, the application is checking your plan to see if you've got this particular thing that you're trying to enter in your plan for that month. And if you do, then certain things happen and are displayed and made required or optional on your forms. So it's really, really important that you keep your plans up to date and that they're correct. And you have to have one for every month of the year in order for your data to be useful. So most of you don't have the option of saying no surveillance, component followed anymore, but so you'll have some kind of plan in place. So one of the changes that we're making to the plan in 2013 for the procedure-associated module, as I said, we're going to be taking away the post-procedure pneumonia. So that part of the that part is going to be missing in 2013. And the other thing is that currently now you say, when you indicate that you have an SSI or that you're going to be monitoring SSIs for a certain procedure, you can click, you can circle in, out, or both. But in the future, beginning in 2013, you'll just be checking a box for in or out, or both. If you can check both in and out, and that will mean both behind the scenes. So you can still do both of them. We just don't have you circle both anymore. Okay? So just some minor change there to the plan. So let's talk about some of the surveillance methods. It is an active surveillance method, just like everything else in NHSN, for surveillance. So you'll determine which surgical patients you want to monitor, either those that you have to for certain regulations or laws, or because you have an interest in your facility for following these particular operations and looking for infections. You'll need to be reviewing admission, readmission, and operating room logs to follow your patients to see where they are, and review patient charts for signs and symptoms of surgical site infection, for any risk factor data that might be required for reporting, and review laboratory, x-ray, other diagnostic test reports to be sure that if you have an organ space infection, you can meet the criteria of that specific organ space site as well as the SSI site. And so that means you do have to review nurses and physician notes. Now, how many of you can do all of this kind of thing from your desk using some combination of electronic or other reports? So a number of you. Well, I would encourage you not to let it stop there. In fact, you really need to go out and visit the units to get that additional information, and also to do, that's an opportunity to do teaching, prevention teaching, look at the environment of care, make sure that things are going the way they should be going in your units. Because remember, as Denise Icardo said, it's all about prevention, right? And so even though we're doing our surveillance, we want to be actively preventing infections as we go along. So if you're just sitting in your office trying to do surveillance, that really doesn't count as active surveillance. You must get out there and talk to people and go and visit your wards. Now, you may not have time to do it every day, but they need to know who you are and that you're an ally, and that this is a team sport. It's not all your responsibility. So let's talk a little about post-discharge surveillance methods. I think there's a misconception that for some reason for CMS you don't have to do post-discharge surveillance to meet that reporting requirement. But that's definitely not the case. There, as you know, as Maggie said already, the follow-up period is 30 days. That's what's being pooled together, and we'll talk more about that in a minute. So patients don't usually stay in the hospital 30 days if the hospital has anything to say about it. So we're going to have some kind of post-discharge surveillance method in place so that we can monitor for infections once the patient leaves the hospital. So how many of you use some combination of surgeon or patient surveys using mail, email, phone, Twitter, whatever, Facebook? Could I see those hands again? So that means a lot of you are doing something else. So I would ask, what are you doing? How many of you are doing nothing? It's okay. We're not going to remember your hand. Right. You're going to have to go to the mic.
Users in the room. Okay, so what we had.
Please step to the mic so we can hear you.
One of our surgeons, he, with another quality analyst, developed what's called a best practice alert. We're a children's hospital, so most of our surgeries, the return follow-up visit does occur in our outpatient clinics.
Okay.
So in order for that surgeon to get out of the chart, they have to address if they have a surgical site infection. And that is for all of our surgeries except for ENTs and fractures.
Okay, so you've got something incorporated into your overall system that requires the surgeons to make a determination. So I would ask, which is great. The thing that you need to be sure is, for any method, is that the surgeons and potentially their office staff, if you're sending something to the office, understand the definitions that you're using and the criteria, that they have to use the same thing that you're using. Otherwise, you're going to have, discrepancies. So, you should develop some kind of tool that includes the surgical site infection and maybe the most common specific infection site criteria for those procedures that are being monitored that they can use. And we've been trying to develop some tools for you to use, and we hope we'll have those ready for you sometime next year. They'll be optional for your use, but just something that we can share. And if you have something that is really good that you think works well, please feel free to share it with us. We'd love to see what kind of tools you've created. I mean, I'm sure many of you are very creative, or you wouldn't be in infection control. And we'd love to see what you have and maybe put it out there for others to look at. So be sure that you have some kind of tool and that your surgeons and their office staff are trained and understand what they're supposed to do, when they're supposed to do it, and that they're using the same definitions that you're using. And again, the criteria have to be met regardless of where the infection is detected. And clinic records is something that this lady shared with us. Okay, so you've seen this slide before. This just focuses on what's required for CMS reporting through NHSN. And in January of this year, as you know, the acute care hospitals had to begin reporting surgical site infections and denominator data for inpatient colon and hysterectomy, abdominal hysterectomy procedures. Now, someone asked me earlier to let you know if we knew what's coming next, which procedures are coming next for CMS, and honestly, we don't know. We haven't heard of any, which is probably a good thing, because that means there won't be anything new for 2013, and we just don't know yet what the next ones will be. But as soon as we know, you will know. Okay, so let's talk a little bit more about the reporting requirements for CMS. So colo and HIST have to be included in your monthly reporting plans every month in order for the data to be reported on your behalf to CMS. So if it's not in the plan, even if you've entered the data, they won't get it. So you've got to make sure you've got those in your plan. And you have to follow the NHSN SSI protocol exactly and report complete and accurate data in a timely manner. That means that you need to report each surgical site infection that's detected or indicate that there was no SSI for that particular procedure for that month. And that for every colo and HIST procedure that are performed on inpatients in your facility, you need to have a record entered into NHSN. And the link there is the guidance that's posted on our website that tells you exactly what's required and how the SIRs will be calculated, as Maggie's already gone through with you. So just to remind you, it's a subset of SSIs that, following in-plan, inpatient colo and HIST procedures that will be used for fulfilling the reporting requirements. And these are patients that are 18 years or older at the time of surgery that have either deep incisional primary or organ space SSIs, so no secondary, no deep incisional secondary, because these don't usually have secondary infections anyway. And they're detected by all of the surveillance methods that during admission, post-discharge, readmission to your facility, or readmission to another facility. So any of the infections that are detected within 30 days of the date of the procedure in those patient groups are the ones that are shared. And as Maggie already mentioned, the risk models will be based on age and ASA. So as the woman asked before the break, why do we have to collect all this other stuff? Well, think of this 2012 risk model as being sort of a provisional model. It was the only one that we could come to agreement with, or to agreement on with the American College of Surgeons at the time that we needed to make that agreement for CMS. That doesn't mean that that's going to always be that way. So what we're hoping to do is continue to work collaboratively with the American College of Surgeons and come up with better risk models using more of the data that we're collecting so that, it'll be a fairer comparison when these SIRs are calculated. So in the NHSN protocol, there's a big table that includes a listing of all of the NHSN operative procedure categories and a listing of their ICD-9 CM and also for certain of them, their CPT codes. And this is just for colo and abdominal hist, just so that you have it accessible. You're going to need, if you haven't already made best friends with someone in medical records, you probably need to. That and the IT people are going to be really important for surgical site infection surveillance. So you don't need to be an expert coder, but you do need to have some understanding of how they're coding things, because if you're reading the op note and you think it's one thing and it gets coded as something else, the records coders are following standard rules that they have to follow. And so you need to be sure that you understand those nuances in order to get things into the database correctly. Now there's one little reporting detail about hysterectomies or abdominal hysterectomies that caused some confusion earlier this year, so I just wanted to have a slide so that it's easy for you to see how this was resolved. So which structures and how they're detached, that is the surgical technique or the approach that used, not the location of where the structures were physically removed, determines how the ICD-9 code is assigned. So what does that mean? It means if there's an assignment of a 68.41 as the ICD-9 code for a laparoscopic total abdominal hysterectomy, then that is one of our HIST categories. And it doesn't matter if the uterus was removed through the vagina. So it doesn't have to be removed through the abdomen. It can be removed through the vagina and still be coded as a 6841 and be considered an abdominal hysterectomy. If it gets coded as a 68.51, then it's considered a laparoscopically assisted vaginal hysterectomy. And usually that does include a vaginal incision. So this is a coding sort of issue that was vetted at the highest levels. There was discrepancy early in the calendar year among medical records coders, and they went to the American College of OBGYN and came to an agreement about how these should be coded, and then we've adopted that in our system. So we just wanted to make sure that you understood that it's not, and we had given conflicting guidance. So we've all got our guidance aligned together, and this is what it is now. Okay, so I mentioned if you, just like with CLABSIs and CAUTIs, if you don't have any to report, you've done the surveillance and nobody got infected, hopefully that's most of the time, then you still need to indicate in NHSN, in the application, that you have no SSIs to report. So to do that, you click on Event Incomplete, which is where the pointer is, and then you click on the Missing PA Events tab, and then you just simply go down and click the box for Report No Events for those procedures in which you had no SSIs that month, okay? And then be sure to hit the Save button, okay? And that will indicate that there are none. What happens if you have a late infection? Well, go ahead and enter that infection, And what will happen is automatically that report no events box will be unchecked for you. So you don't have to remember to go back and do that. It'll do it automatically. Okay? But do look at this and do be aware that if, again, as Maggie was saying, if there are discrepancies when you run some of those reports to see how you're doing, and you think, I know, there should be something here, be sure to look at these incompletes and missing event things to be sure that you haven't forgotten to check the no event box. Okay, let's talk a little bit about the data collection forms. I'm going to go through the denominator for procedure form with you and how to collect the data on the denominator side. And then after lunch, we'll come back together. Is that right? Yeah. After lunch, we'll come back together and Gloria will go through the infection side and define the infection and go through the infection side. And then at the end of the day, we'll do all of our case studies. So one of the key terms that is critical that you understand is what is an NHSN operative procedure. This is not changing in 2013, so that's the good news. But just to remind you, an NHSN operative procedure is a procedure that is performed on a patient who is an NHSN inpatient or outpatient, which I'll define next. It takes place during an operation where a surgeon makes a skin or mucous membrane incision, including a laparoscopic or robotic approach, and primarily closes the incision before the patient leaves the operating room, and is represented by one of the NHSN operative procedure codes that we have in our list. Now, primary closure still means skin-to-skin closure, okay? What's new for 2013 is how we define primary closure. Excuse me. So primary closure in 2013, not this year, but in 2013, will be defined as closure of all tissue levels regardless of the presence of wires, wicks, drains, or other devices or objects extruding through the incision. Okay, so that's clearly different than what we say now. Now we say nothing can be coming out of the incision. But in 2013, we will allow the presence of wires, wicks, drains, or other devices or objects that are in the incision and sticking out of it. However, regardless of whether anything is extruding from the incision, if the skin edges are not fully approximated for the entire length of the incision, for example, they're loosely closed with gaps between the sutures or the staple points, then the incision is not considered primarily closed, and therefore the procedure would not be considered an NHSN operation. And in such cases, any subsequent infection would not be considered an SSI, although it might be considered an HAI if it meets criteria for another specific infection site, like a skin or soft tissue infection. So that part is similar to what we have now. It's just because we now have things that in 2013 we'll have maybe some devices sticking out of an incision, you need to be clear that there are certain surgical techniques where there's this loose closure or whatnot, and we are looking for that approximation around whatever that device is, a drain or a wire or something. So I hear rumbling, not surprised. It still means that you have to read the op note. And again, NHSN surveillance, or this public reporting of these data now, really requires you to have a relationship with your OR and figure out ways that you can get this information onto some kind of data system out of your OR that you can have access to. And that may mean changing the OR sheets and having some information like primary closure, that they can check a box that meets this definition so that it's easy for you to find. So be sure to be discussing this with the surgeons. Now, we have a HICPAC surveillance working group, and we have members of, surgeon members, as well as members from the AORN, the Association for Perioperative Nursing. And we are trying to work hard with them to standardize or to incorporate some of these new changes into the actual records that ORs use. But that's going to take some time, and I would encourage you to begin that discussion and dialogue with your operating room staff as soon as you can to make the surveillance easier for you. All right, one of the other key terms in that definition of an operation is an NHSN inpatient. Again, this is not changing in 2013. These are patients whose date of admission to the healthcare facility and date of discharge are different calendar days. And an outpatient would be a patient whose date of admission to the healthcare facility and date of discharge are the same calendar day. Now, we know that sometimes somebody comes in and they're intended to be an outpatient, but something happens for whatever reason and they end up not going home until the next day. For NHSN, that's an inpatient, even if your billing department calls it something else. So these, again, and depending on the procedures that you do, you'll need to understand how that works in your facility so that you can get your patients into the right categories. Okay, what does an operating room mean in NHSN? An operating room is a patient care area that meets that met the Facilities Guidelines Institute or American Institute of Architects criteria for an operating room when it was constructed or the last time it was renovated. So it needs to meet those guidelines for an operating room. So that might, obviously that's going to include your traditional operating rooms, but it will also probably include your C-section rooms and possibly interventional radiology, although that's something you're going to have to check, and perhaps your cardiac cath lab, and maybe other places where interventions are done that are sort of like surgery or are surgery. So make sure that you understand that. Again, this is a list of from a table in the manual that just shows that each NHSN operative procedure category is defined by a group of ICD-9 procedure codes, and for some of those we do also have CPT codes, but it's important to understand that CPT codes do not take precedence over ICD-9 codes when you're making the categorization and you're trying to figure out, is this one part of a HIST or part of a COLA? They're not, CPT and ICD-9 codes are not a one-to-one match. So there's no easy way to make a complete and accurate list of CPTs to ICD-9s. How many of your inpatient ORs use CPT codes? So a few of you. How many of you think you could get CPT codes if we switched just to CPT codes? Not too many. CPT codes are primarily used for billing purposes, and they're a lot more granular than ICD-9 codes, and they're a lot more up to date, frankly. And as you know, ICD-9 codes are going to be going away anyway, and will be replaced by ICD-10 codes, which is going to mean that in 2014, things are going to change again. So, this SSI surveillance is going to be changing in 2013 and again in 2014. So when Maggie was talking about the models, the SSI models that underpin the SIR calculations, you can see that it's going to be a while before we get to another period of stability in the data, in the way the data are collected and reported, before we can come up with new baseline data. I mean, we could do it now, but it's not going to be good for more than 1 year. because things are changing in 2013. They'll change again in 2014. So this is a dilemma that we just all have to live with until we can come to a place where things are a little bit more stable, and then we've collected enough data that we can re-baseline the SSI data for calculating of both rates and SIRs. So it's a work in progress, and it's going to be a little frustrating, I think, for all of us for a number of years. Okay. So when you choose a procedure that you're going to monitor, then all of the procedures within that category must be followed. So this is just a picture of those for limb amputation, and you can see that there are several codes. Some of them have more, some procedures have fewer, but you cannot pick and choose among the ICD-9 codes. If any of those are done, then you must report a record for that procedure, okay? All right, so let's go through the form and talk about each of the data elements. So the form is just shown here, and this is the one that we'll be using for 2013. So it looks slightly different than the current one. Again, the surveillance period is 1 month, as it is for any of the other NHSN, well, not any of them, but for most of the other patient safety components events. And we complete a procedure, denominator for procedure record for every operation that you're monitoring. That meets the definition of an NHSN operative procedure. And you need to submit the data within a month of the end of this period. So, for example, if your plan indicates that you're going to monitor colo procedures in January and 43 colo procedures were performed that month, then you should enter or import 43 separate colo procedure records into NHSN by the end of February. Now, we all know that there's a much longer lag time for CMS reporting, right? You've got 4.5 months, but I would definitely not wait, because unlike CLABSI surveillance, where you just have one record, one summary record for the month, for SSI surveillance, you're going to have possibly hundreds or thousands of records in a given month that you need to enter, and you can't leave that to the last minute. So make sure that you keep up with this on a monthly basis and get those data entered or imported, and we'll talk about how to import records as well, so that you're not left in a panic come August 15th or whatever the next deadline is. Excuse me. Okay, so the patient information that we collect, the gender and the date of birth are all the same as for any other event. So they're all required. And for the denominator for procedure, we collect the NHSN procedure code as well as the date of procedure. So those are required fields that you'll need to enter. And then next comes outpatient and duration. So outpatient is, it's a required field, and if the admission and discharge dates are the same, calendar date, then you say yes, otherwise you say no. So for most of you, it's going to be no, because you're doing inpatient surveillance. All right? In terms of duration, duration is defined as it's the number of hours and minutes between skin incision and skin closure. Again, that's what we call primary closure. We don't want any of the other times that are listed in the OR record. There's anesthesia time, there's pump time, there's lots of other times, but the only time we want is the incision and closure time. Okay? Now, I've moved some slides around, you may have noticed. Okay, I just moved this one up, that last one up a couple. So the note here is really, really important. In Chapter 9, in the new Chapter 9, which is the SSI chapter, in 2013, be sure that you pay attention to the reporting instructions in the denominator data section of the chapter and the table of instructions that will also be in that chapter, because they really are going to provide some important guidance on many of the nuances of how to report the number of operative procedure records and how you report duration and lots of other things. I'm going to show you some of those this morning, but I'm not going to go through every one of them because your eyes will be glazed over as it is. The reason we have so many of these reporting instructions is because, you've emailed us and you've said, gosh, I have this situation and I can't find guidance on how to do this in the manual. And so what we've done is we've tried to put those in to the manual. Sometimes we put them in the newsletters, but anything that goes in a newsletter is important for us to get into the manual. So we're really trying to get them all into the manual, either in a reporting instruction, a key term, or the table of instructions. So you cannot do SSI surveillance properly without using all those sources. And we're trying to put them together a little bit more carefully in one chapter for you. Okay, so I want to talk about a few of those reporting instructions, and some of these deal with how do you handle duration of operation in various situations. So sometimes you have procedures that have more than one incision, right? So CBGB, coronary artery bypass graft with both a chest and some kind of donor site incision, that would be at least 2 incisions, right? And operations like carotid endarterectomy, CEA, spinal fusion, spinal refusion, and peripheral vascular bypass grafts often have more than one incision to do that particular procedure. Example, again, with CABG, CBGB, you've got the incision to harvest the donor vessel. It could be in the arm, it could be in the leg, and then you've got a separate chest incision. So they harvest the vessel, and then they open the chest and put it in the chest. So you're going to have at least 2 incisions in that case. Another example is for spinal fusion, where there's both an anterior approach, and then they flip the patient over, and then they do the posterior approach. So you're going to have both an abdominal incision and a posterior incision in the back. What we want you to do in these cases for these procedures is only report one denominator for procedure record and record the duration as the time from the first skin incision to primary closure of the last incision. All right, so if you do any of those kinds of procedures, you may have this situation come up, and this is how you handle it. What do you do in the case where you have one incision, but more than one procedure type is done through that single incision? How do you handle that? Well, if procedures in more than one NHSN operative procedure category are done through the same incision during the same trip to the operating room, then you'll want to create a record for each procedure that you're monitoring in your monthly reporting plan and use the total time for the duration for each of the records. So let's do an example. Let's say the patient had a coronary artery bypass graft with a chest incision only. That's a CBGC. And also, at the same time, they did a mitral valve replacement. That happens to be a cardiac procedure. So those are 2 different NHSN procedure categories, but one incision on the patient, right? Everybody got that? Okay. So you're only going to have one skin incision to skin closure, right? So you'll use that time. In this case, in this example, it's 5 hours. You'll report on your CBGC record the duration of 5 hours and 0 minutes, and on the cardiac record, 5 hours and 0 minutes. Does that make sense? What other things do you think would be the same as well? Wound class, ASA, those kind of things will also be the same on those records. Okay? Why do we do that? Well, stay tuned, and I'll tell you. There is a reason. Okay, now, as with any instruction, there's usually an exception, and there is an exception for CBGCs and CBGBs that are done during the same trip to the OR. In that case, we want you to only report one procedure, and that would be a CBGB, okay? So remember what the difference between those two are. A CBGC only has a chest incision. You know, maybe they're just going to use the internal mammary artery. So they just need to crack the chest, find that artery, do the replacement, close it up. One incision just in the chest, right? CBGB, we're harvesting a vein from elsewhere and then putting it into the chest. So, you know, do we really need two separate records? No, we've decided that we just want you to report it as a CBGB. So here's an example. Patient was scheduled to have a coronary artery bypass graft with a chest incision only, a CBGC. However, during the procedure, it became necessary to harvest a vessel from the leg. So basically that gets converted, if you will, for NHSN to a CBGB because now we have two incisions that we're dealing with and a different NHSN code. However, you're going to see probably that the ICD-9 coders will give a code for both a CBGC record and a CBGB record. And so you're going to see both of those, but in this particular case, we only want you to report one CBG record and use the incision to closure time for, again, the first incision from the chest to the closure of the chest. Okay? So if you're doing CABG surveillance, that is something that you will probably run into and have to deal with. And if you've ever tried to enter a CBGB and a CBGC for the patient on the same day, you know that there's an error message and the app won't allow you to do it. Okay, here's another reporting instruction. This one is the situation where the patient returns to the OR within 24 hours of their initial surgery, and they go right back through the same incision, okay? So if the patient goes to the OR more than once during the same admission and another procedure of the same or a different NHSN operative procedure category is performed through that incision within 24 hours of the end of the original incision or the end of the original procedure, report only one denominator for procedure form for the original procedure, combining the durations for both procedures. Okay, let's do an example. Patient had colon surgery performed on Tuesday morning with a duration of 3 hours and 10 minutes. On Tuesday evening, so the same day, he was returned to the OR where the colo incision was opened to repair a bleeding vessel. That happens to have an OTH code in NHSN. So it's not the same procedure. The duration of the second procedure was 1 hour and 10 minutes. In 2013, what we want you to do is report only one colo with a combined duration of 4 hours and 20 minutes. So it's the time of the first procedure, the 310, plus the time of the repair procedure, 1 hour and 10 minutes. So that's a total of 4 hours and 20 minutes. And then we don't want you to report a record for the OTH. Now, most of you would never report an OTH record anyway unless you're in Pennsylvania where you have to. So those of you in Pennsylvania will have a little bit of a break in 2013 in terms of what you have to report. Does that make sense? Yeah, kind of. Okay. All right, one more of these reporting instructions, and that has to do with bilateral procedures. As you know, some procedures, you got two of some things, right? And sometimes they want to work on both of them at the same time during the same trip to the OR. So, for example, a patient could go in and have both knees done at the same time. In this case, we want separate records for each of these procedures because each of them can be independently infected, right? I mean, you could go in and have both knees done and only one of them gets infected and the other one's fine. So you don't want to be combining them all into one. So when it's a bilateral type of operation, then we want two separate records for each procedure, And what may become a problem, though, is sometimes there's only one place on the op note to indicate duration. So in that case, indicate the incision time to closure for each procedure separately. If you can get the times separate, that's great. And if you can't, then use the total time and just split it evenly between the two procedures. Okay? So that hasn't changed. All right, let's talk about wound class. So wound class is a required field, and you can see that in 2013 it's not changing. We still have the unknown category, but that will be going away, I can tell you, in 2014. So please, if you have ever reported or you have unknown sometimes, you need to start working on it now to be sure that you have a way of categorizing those, because if you won't be able to save the record if it's unknown in the future. Wound class, as you know, is an assessment of the likelihood and degree of contamination of the surgical wound at the time of the operation. And it should be assigned by someone directly involved in the procedure in performing the operation, and it should not be your responsibility to assign it. Now, obviously, when you're reviewing records, you're going to see things that make your hair stand on end. So, with respect to wound class, so this is another area of conversation that you need to be having if you haven't already had it with your ORs this year, just to make sure that they're assigning these things properly. Again, the HICPAC Surveillance Working Group is addressing wound class, and we will be making some clarifications and probably some changes for 2014, maybe not anything for 2013. Just to remind you, and these currently are in the key terms section of the NHSN manual, but these are the definitions of wound class. And I've just starred something that isn't currently in the chapter or in the definitions, it's because it's a question we get asked a lot. So I've starred here genital tract for both clean and clean contaminated, because we include the female and male reproductive tracts in that catch-all phrase of genital. And I know that's caused confusion around hysterectomies. People are not always understood that you really can't have a clean hysterectomy. So we would consider those at least clean contaminated, if not dirtier than that. Okay? So that's for clarification there. And for class 3 and class 4, these are the current definitions. They're not changing for 2013. So let's do a couple of examples of wound class. And that's so Suzanne had this is different. I've modified this from what's in your handout, so you may want to change this. This first one. Suzanne had an appendectomy following 1 day of acute abdominal pain with rebound tenderness. At the end of the case, the surgeon indicates that the appendix was inflamed and the surgical area was irrigated, and cefoxitin was ordered for 3 days post-operatively. We would expect that to be a class 3, right? Because let's go back and look at class 3. We had incision into an acute, non-purulent, inflamed tissue. We didn't have a frank infection there, all right? So we would expect that would be coded as a class 3. Okay, the second one, Fred had a cholecystectomy using a laparoscopic technique. The gallbladder was removed successfully with no breaks in operative asepsis. So we would expect that should be coded as a 2. And again, let's look at that. We entered the alimentary tract under controlled conditions without unusual contamination. All right? And it specifically also says that biliary tract is included in this if there are no infection evidence or break-in technique. Number 4, George had a knee prosthesis revision. When the surgeon makes the incision into the surgical site, she notes that the knee joint demonstrates purulent material and inflammation. A specimen is obtained and sent to the laboratory, which grows methicillin-sensitive Staph aureus. Because this is infected already at the time of surgery, we would expect a wound class of 4 to be assigned to this one. And then finally, this is one we've had a number of questions on that we added for this class. Mary had a scheduled uneventful abdominal hysterectomy. Again, we would expect that to be a wound class of 2. All right? All right, let's move on to the next data field, which is general anesthesia. Again, no changes for 2013. We define general anesthesia as the administration of drugs or gases that enter the general circulation and affect the central nervous system to render the patient pain-free, amnesic, unconscious, and often paralyzed with relaxed muscles. All right? Sounds good. You ready for that? I think that starts over at the Emory Conference Center at about 5 o'clock. All right, ASA class. The ASA class, or ASA score, is a 5-level system of scoring that is developed by anesthesiology, and it looks at the preoperative physical condition of the patient. And so the anesthesiologist or nurse anesthetist should be coming in and assessing the patient and giving the score that is put on the op note for you. Is there anybody that doesn't have this information available to them on an inpatient type of procedure? Okay, good. Okay, ASA class is only required for inpatient procedures. So on the form, it doesn't have an asterisk next to it because it's a conditionally required field. So if, again, in your plan, or in the form, on the record, if you've indicated this is an outpatient procedure, then you won't have to do ASA score because they don't often assign it in outpatient procedures. If it's there, that's great, you can use it. But it's not required unless the patient's an inpatient. And these are the definitions. Again, none of this has changed for the 5 different wound classes. And we use it as a proxy measure for, again, the underlying severity of illness as one of the factors that is associated for risk of surgical site infection. And that's why it's included in many of our risk models that we've published and Maggie mentioned earlier. Okay, emergency. Emergency is simply defined as a non-elective and unscheduled operation. If it's that, then you, if it's unscheduled and non-elective, then you would say yes to this question. All right? For trauma, again, we have a simple definition. If an operation was done because of blunt or penetrating trauma, then you select yes. If that's the reason they're doing the surgery, then you select yes. Now, sometimes the trauma occurs, days out, and it may not be the reason anymore that they're doing the surgery. So that may be something that you'll have to determine. We've changed the name of endoscope to scope. And the only reason that we did that is because it's a little more generic and it's a little easier to for the surgeons to get their arms around. So it hasn't changed in terms of its meaning, but you'll see that it's called scope now instead of endoscope in 2013. And we're still saying that if the entire procedure was performed using a laparoscope or a robotic assist, because we kind of see those as equivalent to each other, then you would select yes. Now, there are some caveats here. If it started out as a laparoscopic approach, but they had to extend the incision so that they could assist using their hand to pull out whatever it is they're trying to pull out and visualize better or operate on, then you would have to say no there. And then also if they just end up having to fully convert to an open approach. So it's not just a hand assist, but they start with the lap and then they end up, things are more complicated than they expected, and they do a full incision, then that needs to be considered an open approach rather than laparoscopic. And usually you'll be able to tell that by the op note, and also you might be able to tell it by the nursing notes in terms of the incision care, the wound care afterwards, whether or not that involves just the little trocar incisions for the laparoscope, or if there's really an incision there now that has to be dressed and taken care of. So those are a couple of sources of data you can use there. So again, if for scope regarding HIST or VHIST, make sure that you say yes, regardless of how the uterus was removed, whether it was through the abdomen or through the vagina. And again, those ICD-9 codes will help you after the fact to know whether you've picked the right category. And finally, there is again, with cabbages, the CBGBs, we do, if they use a scope to harvest the donor vessel, then we ask you to, this is a little bit of an exception, we do ask you to indicate yes, even though the entire procedure wasn't done with the scope. Okay, so this is an exception. And the reason for that is, as you may recall, or you'll learn about later this afternoon, is we have a way of distinguishing between primary incisions and secondary incisions. So if for a CBGB, scope equals yes, then we assume it's for the harvest, not for the chest, all right? If you say CBGC with a scope, then we know there's only a chest incision, and it was a mini cab or something like that was done, and they didn't crack the sternum. Okay, so it's just a way for us to keep track of which incisions are likely to get infected. So this is one exception when it comes to the entire operative procedure rule for CBGB. All right, everybody clear on that? I know that some people have been confused about that in the past. Okay. All right, surgeon code is optional. However, for prevention purposes, I think all of you should be collecting it, but we will never use it at CDC because we don't know who your surgeons are and we can't decipher your codes. So there is a way for you to indicate a code or the surgeon name if you choose, and you can set up those code lists for your surgeons and then enter that, and that way you can calculate risk adjusted metrics by surgeon or surgeon group if you want to. And if you do have more than one surgeon performing the operation, then you'll want to enter the code for the surgeon who was primarily responsible for the case. And if you have teams of surgeons that typically work together, you may want to make a team code and use that rather than an individual surgeon code. So those are some ways you can organize your surgeon data. All right, so here's the big news that hopefully you'll be happy about, is that for 2013, you're no longer going to have to tell us about implants. So you don't have to follow implants anymore. You don't have to figure out whether something's an implant. Yay! And what goes along with that, as of course you know, is with implants you had to follow certain infections for up to a year. But instead, we're going to have certain operative procedures that would require monitoring for either 30 days or 90 days, depending on the procedure type, and I'll show you that list in a minute, when you're identifying deep incisional or organ space infections. And why did we do this? Well, we finally just said, you know, there's too many implants, and it's not really helping us that much with the stratification of the surgical site infection data. And also, we heard you loud and clear that it's really difficult to collect the data. It's difficult to be consistent across data collectors. And a lot of things that are really implants are not even documented in a chart or an OR record. So we've just decided that we will not use implant anymore in 2013, and instead we'll just have a follow-up period that is required for certain procedures. And that list actually, I think Gloria is going to show you when she does her presentation. Okay, so let's talk about a few other things. And there are certain additional fields for some procedures that are required. So I want to run through those with you in case you're monitoring those. So for 5 procedures, we collect additional risk factors: cesarean section, spinal fusion, spinal refusion, hip and knee arthroplasties. And when any of these procedures are included in your monthly plan, then you must collect these additional data. So for C-section, we collect height and weight, height in feet or in inches or in meters, and weight in pounds or kilograms. And that's so we can calculate so we can calculate obesity and or body mass index to determine obesity. And then the number of hours in labor in the hospital, okay? And we used to collect estimated blood loss, but that went away at the beginning of this year, okay? So we're not collecting that anymore. So height, weight, and duration of labor, if you're monitoring C-sections, would be additional data that you have to report. And just a note on labor for those of you who do follow this, we've added a little bit more detail, or we will be adding it in 2013. So labor is defined as the length of time from beginning of active labor as an inpatient to delivery of the infant, and it's expressed in hours. So if it's less than or equal to 30 minutes, you round down to the nearest whole hour. If it's which would be 0. And if it's greater than 30 minutes, you round up. And if there's no labor, then it's 0, okay? You need to look for that documentation in the chart, and labor can be defined by your hospital's policies and procedures, but it should reflect the onset of regular contractions or induction that leads to delivery during this admission. Okay, so we're looking at just the information that should be available to you within the hospital admission. Okay? For spinal fusions and refusions, we collect data on spinal level, on diabetes, and the approach or technique. So you indicate which procedure you're monitoring, and then check the appropriate spinal level, and then whether or not the patient is diabetic, and the appropriate or the approach that was used. And all of that should be documented because they're all indicated by ICD-9 code. For hips, we have you tell us the type of hip procedure, whether it was total primary, total revision, or partial revision. This will change in 2014. All right, it'll be a lot different in 2014 than it is in 2013. We wanted to make the change in 2013, but we couldn't do it. So you can expect that if you're monitoring these procedures, that it will look different in 2014, and we'll let you know what it's going to be as the time gets closer. Same thing with knee prosthesis. This is no different for 2013 than it is in 2012, but it will change in 2014. Okay? So to sum up this part, I just will say that you need to complete and enter or import a denominator for procedure record for every NHSN operative procedure performed that is selected for surveillance. So anyone, it's not only the ones that have infections, it's all of them. And you need to be sure to use the protocol, the table of instructions, and the key terms that I mentioned as resources in order to help guide you to report and collect the data appropriately. All right, so let's move on and talk a little bit about linking and importing records. So in order for the NHSN tool to, in order to keep the data entry or simple or simpler in the NHSN application, we have this linking procedure so that we can pull together the information in the denominator record with that in the infection record without you having to reproduce it, so that we can get a match on the two records, okay? So one of the most important things to remember is that you must enter your denominator for procedure record before you try to enter an SSI record. You cannot link an SSI record to something that isn't there, right? So that doesn't mean you have to import or enter all your procedures. You know, let's say you find your infection, but you haven't gotten your denominators entered yet. You could enter that one denominator record and then enter your SSI and get that linkage done, and then later enter the rest of your procedures, okay? So enter the record, the denominator record first, and then enter or import your SSI record, and then link the two. So in the app, when you're in the event type, you select event type field on your add event screen, and you've indicated that you've got a surgical site infection, and then the screen repaints and you see this button come up that says link, unlink to procedure. And if you simply go down once the screen repaints and click on this button, it will bring up a list for that patient of all the operative procedures that patient has had. So it may only be one procedure, as it is in this case, and that if that's the procedure you want to link to, then all you do is go over and click the box and then click link unlink here or down here. It doesn't matter. All right? And then when it will take you, the app will take you back to your event record, and you'll see the information pulled over automatically for you. So you don't have to retype it in there. Just indicate it's an SSI, click the link button, click yes, I want to link this procedure, and it'll fill in the details for you. Now, that doesn't mean that you're done, right? It just means that the next thing you need to do is finish entering the other information so that you can save the record. So you'll have to enter your date of event and the location, although that's optional now, and the facility date, etc. Okay? So once you finish entering your SSI record and click the save button, then that means the data are linked together and you're good to go. And then when you go to analysis, then that infection is always going to be tied to that procedure for the rate calculations, for the SIR calculations, et cetera. Okay? All right, let's talk about import. How many of you use the CSV type of import? Great. How many of you are trying to get that together in your hospital but have had trouble? A few. All right. So that's why we say you need your IT person to be one of your best friends, because it does take a little action on their part to get you started. And if you haven't done this yet, we really, really encourage you to try to do it, because it will save you a ton of time. How many of you use the CDA method of import from a vendor, another vendor? So some of you. So that's good too. That also saves you a lot of time. So to get information about importing You can go out to the NHSN website on the public website, go to the resource library, and then on that page, just click on Patient Safety Component Resources, and it'll bring you down to these options that are listed here, where you see a document for how to import the procedure data, and then another one with the file specifications for the import, and then a sample of an import of a CSV or a spreadsheet type of file that you can practice importing, or you can look at it, not practice importing, but you can look at it and see if it's yours is formed the same way as that one. And this is just a screenshot of that file specification document, and you'll probably want to print it out and give it and go over it with your IT folks. What it shows you on the top here, for example, is it'll go through and list all of the fields that we've just reviewed. So from patient ID through the optional custom fields. And it tells you whether that field is required or not required, what values that particular field has, and then how long and what format those fields are in. So for example, in gender, the values are M, F, and actually there's another one, an other now. And it's a character type field of one, a length of 1, whereas the date of birth is also required, and it's in the MMDDYYYY format. So it gives the specification, and you can see then that a column in the spreadsheet is where the information for each of these fields goes. So this first column would be the patient ID data. The second column would be where the gender information goes, and the third column would be, the date of birth, et cetera. So it's just each column then in your spreadsheet is where this information goes. And it is called a comma-separated file because it actually is laid out as a long string of data separated by an actual comma. So even if you don't have information, you're not required to capture information, you still need to have that column accounted for, or the file will not import properly. In addition, there are some fields that are marked optional for import. So we've seen required, we saw optional, but there's another category called optional for import. And for example, for C-section patients, the height, the weight, and the duration of labor are optional for import, meaning if you can't get that information out of your OR, which is unlikely, right? They're not going to usually have that information there. Then you will have to enter those data. After you get your import, you'll need to go into that file and put those values in there. Or you can actually import the file and enter them in NHSN. A screen will be available for you to do that. Okay, so that's that. And then finally, when you're creating the spreadsheet, if you include what's called a header row, where you've got the, a label for what's in each of the columns, which is a really good thing to have when you first create it, so you know you're putting things in the right order. Be sure you delete that header row before you try to import the data. Otherwise, it will not import properly. Okay? And once you have this set up, it works pretty well. So the hard part is getting it set up, and we're definitely here you can email us if you're having problems, and we'll try to work with you to get this set up so that you can import your data. You may, again, you're going to need some IT help probably to get the information from your OR, but we can work with you and your IT person to help make this happen for you. I just wanted to show you that if you're in the NHSN application, there is also a help. You can use the NHSN help system to get this same kind of information. And to do that, you would go to the import-export link and then indicate procedures. And then if you click on help here, it will take you to the help system, and it'll guide you through what we just saw. So you can find that information in the help system. If you lose your notes, you can always go there. Plus, it's out on the website. So we've got it for you in a variety of places to help you get that done. It's really, really a time saver, and it's worth the effort that you put into it to get it done. So just a couple of other resources before we wrap it up and take questions. There's a huge document that hopefully you're familiar with. It's a big spreadsheet, and it is a mapping of all the ICD-9-CM procedure codes, all of them, from 00.01 through 99.99. And in that spreadsheet, we have whether or not a particular code is mapped to an NHSN operative procedure code or OTH, whether or not it's considered a non-operation or an NO in NHSN, or whether it actually doesn't really exist yet. So we put in placeholders even for codes that don't yet exist. So if you're ever, have an ICD-9 code and you're not sure whether it's an NHSN procedure or not, you can go to this spreadsheet and find it very quickly and figure out whether or not it should be something that is included in your reporting. And then, as others have mentioned, we do have our interactive training courses online that you can do anytime. We will be updating these with the new information. So, if you need a refresher, January, and you want to try the interactive training courses, they should be posted. If they're not posted, the web streaming, again, will be posted, and we will be setting up Q&A times for those for each topic in the coming months. Okay, so with that, I'll stop, and we've got time for questions. In fact, we have lots of time for questions, and if we finish our questions early, we'll be able to go to lunch early as well. Yes? Oh, go
One
ahead.
of our medical coders has pointed out to us that under the COLO ICD-9 codes, there's a separate code for colostomies, and they're wondering why that is, since it's not a primary closure, I would assume, so.
So that's going to be discussed this afternoon. We do consider that primary closure, though. Colostomies we do consider as, in a way, in my mind, the way I sort of justify that, it's like a drain, right, that you put in adjacent to the actual incision. So we do include colostomy procedures as those that are primarily closed.
Thank you.
Yep.
When is the 2013 going to be out, the manual?
We hope it'll be out towards the middle to end of December. That's our goal.
Okay, thanks.
We didn't want to put it out too soon because we don't want people using it now. So, yes.
I work for a large hospital system that performs lots of the three type of procedures that we're currently reporting. And because of the volume, our goal is to automate as much as possible, because otherwise it's unmanageable. But as we're looking at the rules for combining procedures and the various exceptions of pulling the data over from our OR system, those exceptions make it impossible to fully automate the process. Is there a possibility moving forward for you guys to consider simplifying those in such a way that we're able to simply take the fields from what the nurse enters in the OR and make it more intuitive so that there's not that manual element?
We've certainly discussed this, and we'll continue to discuss it with the working group. We also have IPs on the working group and the state health department representatives, et cetera. So, we understand that it's problematic. It comes down to how useful are the data going to be if we don't. Well, let me put it this way. The struggle that we're in right now is a struggle between clinical credibility of our data and consistency of the data. And so we could make things very simple and very easy to be consistent, and that will pull us further away from clinical credibility. And since we're trying to influence the clinicians with the data so that they can work on better prevention, that becomes the big dilemma. So it's this balance that we're trying to find between keeping, making the data clinically credible, yet making the collection, reporting consistent and easy to do. That is the real challenge these days. So we'll continue to talk about it. We know that it's difficult, and we are trying to simplify as much as we can. Yes, ma'am.
I have a question for the group. I'd like to know if anyone else is dealing with the McKesson HSM OR system. And if you are, can you come and talk to me and give me some good news?
So did everybody hear that cry for help?
So I'm right here at the front. So.
Okay, she's at the front table. Anybody that has a McKesson system would like to talk to her.
I am only familiar with reporting the COLO and HIS and NHSN, so all of mine are in-plan reporting. I just would like to hear from you, as I'm hearing more and more about the statistical analysis and listening to you today, I see the value of doing additional SSI reporting into NHSN. Mm-hmm. Why would you not, or would you include that in plan? I'm not sure what in plan, what the importance of in plan means, except for including in plan for a CMS reporting.
Yeah. So in general, your question is why would you want to put something in plan versus not? Yeah. So one of the main drivers of putting something in plan is that you're committed to following the protocol. For me, that's number one. All right. So if you want to deviate in any way, don't put it in your plan. But if you're willing to follow the protocol exactly, then I would encourage you to put it in your plan, because then all the business rules will be in play, and it will keep you, as you're entering your data, from making mistakes. If something is entered off plan, there are no business rules. There are virtually none. There are a few, but there are virtually none. So that means that you could put in a value that makes no sense just because you're quickly typing, and it wouldn't be caught. And so you end up with, you could end up with some nonsense. So putting it in plan helps you to get better data because you're not, it's going to edit check as you go. So that's one thing. And on the analysis side, you can analyze your data in or out of plan, so you have that flexibility. But that's what I would say.
And
the other thing is that we would be able to use it in the aggregate, and so that's very helpful to everyone. If you've actually followed the rules and it's in plan, then it will go in the national database. Otherwise, it doesn't.
And CMS is only allowed to pull COLO and HIS at this time, regardless of what you have in plan.
That's right. And CMS does not ever access the database. We give them the data on your behalf. That was part of the agreement that you signed when you joined NHSN, allowing us to do that in your behalf. So they don't have access to the data. They only get what is specified, as we've described, in a data set.
And so at the beginning of my year, if I decide to include 6 procedures in plan, and 6 months into the year we have other unforeseen issues happening and have to make the decision that we can no longer follow 2 procedures, can we change mid-year what's in plan.
Yes. You can always modify your plan at any time. You can't delete a plan, but you can
Right.
modify it any time.
Okay.
I think it's the other thing about that, I don't know what state you're in, but a lot of the state health department reporting only uses in-plan data as well.
Right.
So that they may only have access to your in-plan stuff. So if you want them to have access to it, for whatever reason, maybe there's a collaborative, or, a lot of researchers now are accessing NHSN data, and they will only typically use in-plan data as well. So it makes your data available to good causes, if you will, if you're willing to do that, and you've agreed as part of being in a group or something.
Okay, thank you.
In the back first, thank you.
Thank you for a very informative presentation. I think with all this data, it will give us a richer and more robust database. But is there any thought about increasing the mandate for ICPs in facilities to assist us with this process?
I only wish we had that kind of power. No,
But you do.
Well, we really don't. I think that question has been asked for at least 20 of the 28 years I've worked here. And we've had, working groups with APIC and others trying to figure out, what is the magic number of IPs needed and that. And it's not an easy thing to do. But I think that it's being recognized how difficult this is and how much IPs do. I mean, this is just one part of your job. And here you are spending 3 days focused on it. That's a big deal. You've got all the prevention work to do. A lot of you have employee health stuff that you have to do, and on, teaching, et cetera. You know what you do. So I think, one thing I'll get on my soapbox a little bit. One thing I think IPs need to realize and to embrace is that this is not their total responsibility. This is a hospital commitment. Once CMS entered the picture, they upped the ante. And, you've been trying to get administrative support all along, I'm sure. Well, now you've got it. They may not have given you additional resources yet, but if they don't get paid because you haven't had the help that you need, that gets their attention. So I think we need to sort of be creative and work with the administrators to let them understand that, I cannot do this by myself. I need this information from the OR. It has to become a priority. I need, this, that, and the other if we're going to get this done. So, we keep trying to give that message as much as we can to these other entities, and hopefully it's helping, but I don't think we're ever going to be able to say you need one IP per X number of whatever. It wouldn't be beds anymore anyway. It would be something else. And so we'll try to do it in other ways. Yeah. In the front here, please.
I just wanted to add to that.
Oh, sorry.
Sorry.
I can't hear you.
I just wanted to add to that real quick if I could for all those IPs that are now struggling with in front of the computer and all of the data reporting and not getting on the floor as much as they wish. With public reporting of the core measures that all hospitals started back in the early 2000s, saw the same thing really, that someone in the QI department was given their OREX or CART tool and told to start abstracting, and today, if you look at that same program now and the processes in place to ensure they get their APU, there's quite a few more FTEs involved in the process these days. And it's the growing pains you're sitting through right now, but it is the positive move to get much more on HAI prevention for you.
Thanks, Charlie.
I've got a couple of questions. A couple of my hospitals feel like they haven't gotten clear direction on one question that they've asked, is if they've got two, especially trauma patients, that they have surgical procedures like a AAA and then have pelvic fractures and get hardware in a second spot, and then there's infection, which kind of all over the patient, and which they do 2 separate denominator forms for the 2 separate NHSN codes, and then you report surgical site infections for both, or how do you determine which was the primary?
Right. Well, so a lot of that depends on how many incisions you have, right? So if you have an incision for the AAA and say an incision for the fracture, then you have 2 different operative procedures, right? So 2 different records.
Okay.
You have a record for each. If they're in your plan, right? That's the other caveat. They got to be in plan. Then you have to have a record for each. And each of those has their own wound class, duration, et cetera, et cetera. And then, depending on where the infection is, it's either going to be in one or the other incision site. I think in the scenario you're describing, you'd never have sort of a common organ space one that you'd have to sort out. But that's another issue that we'll talk about this afternoon. So I think in your case, it would be pretty straightforward. 2 records, and if infection occurred at either of those sites, then those infections would be reported as well.
And we had heard that height, weight, and diabetes were going to be added to the denominator form in 2013. Is that not going to happen?
We wish, but no, you're saved another year. That got pushed back to 2014.
Okay. And then just something I might want to mention, just in helping a lot of hospitals get hooked up. The import instructions are excellent online, but if you use that different help rather than NHSN at cdc.gov, use the NHSN CDA, different help, that gets it to Paul's group and he answers right away. That's really been helpful to have a separate and help email.
Good. Well, I'm sorry that Paul isn't here right now to hear that, but we'll make sure to pass that along to him. In the back?
Yes, ma'am. My question is in regards to primary closure. It states here, I understand that many times the surgeon may close the skin, but the patient is technically left open for operative, purposes. They may go back in, the fascia is not closed. How can you have primary closure if the skin edges are not fully approximated for the entire length of the incision? You can't have a wick or a drain and the incision be fully approximated. Can you explain that to me, please?
Yeah. What we've heard is that sometimes, usually if there's a wick or a drain, then the incision is closed all the way up to that point, right? And it's
not necessarily.
Well, so that's the issue that you're going to have to figure out. And sometimes there's this, for whatever reasons, they might close like this. It's a big, obviously, somebody's maybe not that big, but there will be big gaps and open areas. So that we would consider not primarily closed. So, and sometimes you might have a wick in one of them and then another nothing. So in that case, we would say not primarily closed. Now, why do we care about that? Right? Because the wound can be contaminated after surgery, right?
Absolutely.
And we don't want to include those in our ones that are primarily closed because they really have different risk factors. So I know that makes it difficult for surveillance, no question. I'm not trying to minimize that, and that's why you have to begin to understand and work with your surgeons and find out what they do, what are their techniques, and we've had feedback from hospitals. New York, for example, has been requiring colon surveillance for a number of years now. And so they were the first ones to start asking all these questions about primary closure because they were finding these techniques that were, pretty much unknown to us. And so we had to make some decisions about how to handle them. So it does make it more difficult, but again, if you work with the surgeons and you know who's doing what, then you can be on the lookout for them and how they're managing those particular patients. And so it may not be everybody you have to look at. It may just be a few surgeons and their patients.
Thank you.
Yes.
I just want to say fantastic sessions, and it's so exciting to be here at the CDC. Just data entry ease. Is there any thinking about consideration of when we enter the antibiotic susceptibility with the organisms, to have it in alphabetical order to make it a little easier to go through.
Yeah, there's actually, it's so funny because when we first developed NHSN, we never intended, we struggled. That was the one thing we struggled with a lot is, how do we make the antibiograms easier to enter? Because believe it or not, in the old NIST-DOS system, it was easier. And, to think that when you move to the internet, it's going to be harder was really a hard pill for us to swallow, let alone, to put out there for you to do. And so, it's been modified once, not so satisfactorily. And it's still something that we are continuing to work on. We do have a change request in to spend some more time. During our usability study that we've conducted last year, that came through loud and clear. And not that we didn't know it already, but we will be trying to find a way to make it easier for you to get those susceptibility data in.
Great. And on another addition, if you could put on your change form, perhaps, if we have like multiple units that we're entering information on, it would be so awesome to see all of our different units, and then you put in all admission days, all patient days, all
Yep.
line
It's actually
days,
built
et cetera.
already.
Yeah.
But
Awesome.
it's not quite final, so I'm not sure. I don't know if anybody knows off the top of their head whether that will be January or not. It was supposed to be released in October, so we have it. So I don't know if you understand what she's saying. Basically, as you know now, for entering your summary denominator type records, it's one record per month, and so you have to keep adding records. And so what we're doing is we're basically making it into a line list. So, and it will be driven by the plan. So when you go to enter denominator records, say for ICU or whatever, actually for an event type, all of the locations in your plan will automatically show up. And what's required will be there, and you'll just be able to go across and check boxes or enter numbers and handle it that way. So it will be a lot easier, but it's been a real challenge to actually make that happen. We all thought this is a great idea, but the nuances of making the application work properly has been a bit more of a challenge than we thought. So hopefully that'll be in our January release as well.
And finally, why did you add that we have to check no events? Because that's kind of a little bit of a pain.
Yes. We added that actually at the request of the state health departments. Because, well, yeah, and I think it's a good thing. It keeps them from calling you to find out whether or not you didn't, you forgot to report or whatever. So, it really is a way of verifying that you didn't just forget to enter something, because a lot of times you do forget. So that's really all it's for.
Thank you. And NHSN team, thank you for listening to us.
Yeah, you're welcome.
Hey, thanks for all the work that obviously has gone into all of these revisions and changes, and I can't even imagine the logistics of all of this. But that being said, I knew that VAA...
Could you speak in the mic a little bit more so we can hear you? Thanks.
That being said, I knew that the VAE definitions were certainly changing in January, but I did not realize, and I knew all of the definitions were being worked on, but I didn't realize all of the changes that were going to be implemented starting January 2013, and it being October 2013. So particularly like things like primary wound closure. I guess my question is not so much to you, but to the other folks in the room. Am I the only one that's going to be challenged with making sure all of the clinicians understand these changes and get all of this done in the next 8 weeks?
Well, a little bit to our defense, we actually have had information on this since June, since APIC. We presented at APIC in the NHSN meeting, and that information has been out there since then. Now, some of it's changed a little bit, and it hasn't been in as much detail as you've heard today.
Yeah, a lot
but
more
we've
detail.
been trying to warn you for a while that things would be changing.
Yeah.
Everybody's going to struggle. There's no question about that. And that's why we wanted this course as soon as we could get it.
And I really appreciate that.
But it will be a challenge, there's no question.
And do you have, as coming from a health system that bases everything on the top 10 percentile of NHSN for our HAIs, they want everything within the top 10 percentile. Do you have any suggestions as to how I relate to our senior leaders, the change in the baseline given the changes in the definitions? Because like SSIs is certainly going to change, as you've already said, for 2013 and then change again in 2014.
Right.
So collecting that baseline data is going to take time.
Oh, yeah.
So
Yeah.
any pearly words of wisdom is how I relay that. And
Well, I think, the best thing you can say to them is that, some of these changes will impact the data, the way I collect data, the way the data are analyzed, and therefore, while you may want this kind of information for your dashboard or whatever, just recognize that it is going to be changing and that we're not going to have a good baseline. We meaning your hospital and we meaning the nation for a while. And that happens in surveillance. I mean, when they change the HIV definition, you have to wait before you really understand the impact of, that reporting change has made on the data. So I don't really have any other words of wisdom. I think that's just something that we all have to work on with our administrators to let them know the nature of the changes and that they will change the data.
okay,
All
thank
right,
you.
thanks.
Great job, Teresa.
Thanks.
I have always been baffled by location being present on the SSI form.
It's optional.
I understand, but the way I'm reading it is that it's conditionally required to be filled in if you're doing MDRO.
Right.
And the organism let's say MRSA was detected and the geographic location would have been a surgical post-op unit for that patient that was in plan.
Right.
And with 2013 coming and a lot more participation or mandatory participation in the MDRO, I'm wondering about the build-in of the locations, the other geographic locations for the facility. In other words, if you put a location in there, it has to be a location that's in your location table, correct?
Right. Absolutely.
So the build-in of all of those geographic locations going forward, because we're going to be checking yes for MDRO in plan, I would imagine, which means location would no longer be conditionally required on the SSI form, right?
Well, remember for CMS reporting, and we'll do this tomorrow, it's lab ID event, not infection. So you're not even going to be looking at the SSI form for that reporting requirement. Now, you will still have to put location in, though. So that is something that I'm sure Angela will talk about tomorrow. But if you haven't already entered all your locations into the location manager of the NHSN application, you need to start on that, too. That's one more thing. That's really where you're going. Yeah, and Angela will talk more about that tomorrow. Yes.
I had a follow-up on my previous question as I had time to sit and think about it. And let me preface with, I have great respect for what you guys do, and I'm constantly in awe, I think, of what you guys do. But you talked about validity of the data, and the issue with being able to really automate the data was to ensure that it was valid. And I guess I wanted to ensure that you guys knew the concern from the other end is if we're not able to automate the data as we send it to you, I think the validity of the data on our side and the quality of the data may be compromised because of the burden. And I'm picturing as we're going through these reports, if we don't have the time or the resources to be able to send you 300 denominator sheets completely filled out every month, we send what we can, and we send we make the decisions for what the best data is, but we don't have the time and the resources to to focus on improving that data. So I thought I would throw that out there too, is that, I mean, there's certainly a quality validity issue on that side, supporting the reduction of the burden.
No, absolutely. I mean, I think that goes without saying. There is, as I think Charlie mentioned, we're in a situation now where you're being asked to do way more than you have the resources to do. You know, when NHSN was when we transitioned the NIST system to NHSN, remember, it was a totally voluntary system. And only people that wanted to do it and had the resources to do it did it. So the system was built on the principle that it would be a voluntary reporting system. And it has been, because we had some useful features for data sharing, it has been easy for state health departments, CMS, and others to use the system rather than create a new one, and that makes sense. We don't want to spend money we don't have to spend. But we're trying to put a bit of a square peg into a round hole at this point. And so what we're working on is trying to get those two to be more of the same shape. And we're just in a growing pains period, and unfortunately you're in, at ground zero of that, and, paying the price. So the resource issue is one that, we continue to work on at, our levels to try to make the big associations of like AHA and get them on our side and help them to understand that you need to do what you can do to help these IPs get the resources they need, and work on the IT resources in terms of meaningful use that Dr. Pollack talked about. I mean, as you can imagine, just like everything else in healthcare, it's multifactorial. So trying to get the ball moving is in forward motion is what we're doing, and we can do what we can do, but you're going to have to do what you can do on your level. And we recognize if you're doing the best you can do, that's all we can ask. I can't tell you that a validator isn't going to come behind you and say you didn't do well. That will happen at some point, hopefully not in the near future. Hopefully you'll have time to get your processes in order as well. And but that's just where we are at the moment.
Let me clarify, my hospital system's data is perfect.
Of course.
just so we're clear, ours is fine. I was talking about everybody else. Yeah.
Well, good. They may all want to come work for you.
Just to build a little bit on what she said, I think it would be really helpful if CDC wrote a letter to either hospital associations in the different states or people that run hospitals, CEOs, because these folks have no clue what we do. None. I've tried in vain to, delineate how all the hours are spent, and they just don't get it.
Yeah.
And they're in the mode for saving money, and arbitrarily they're cutting resources.
Right.
To the point where we're going to have to end up putting in work that's not good.
Yeah.
And not up to the level we want it to be. And I don't know about anybody else here, but I'm not real comfortable with that.
Yeah. Well,
And
I hear
if you
you.
don't talk to COOs, I think CDC always seems to back off of making a statement that you really need to help your IPs and think about those resources because we need this data. And I don't see what CDC would be risking by doing that. I really don't.
Let me just mention that we do have regular meetings, monthly meetings with AHA, their top leadership. They are the ones that want to make the communications to the executives in the hospital. I know we have written letters to CEOs before, and I can tell you they've gone nowhere. So we can try again. I'm not, I'm not saying we can't, but I'm not as optimistic as you are that it will actually have the effect that you want. But I will carry that message forward.
Just very quickly, Teresa, I do appreciate on the bottom of each form that we use to figure out if we have an infection or not, that it says it takes 22 minutes of time or something to that effect. Well, that's for every non-infection as well. It's not just for every infection.
Right.
We investigate thinking that there may or may not be an
Sure.
infection. We put in all that time and it wasn't, which is a good thing, but I like that the number is on there. So you multiply that times every patient you look at.
Yeah. Oh, that's an excellent point. And, you know, it's funny, the reason that those numbers are on there is because in order for us to collect data at the federal level, we have to have what's called OMB clearance. Office of Management and Budget is supposed to be looking out for all of its citizens and keeping the big brother government from, you know, asking you a million questions. And so in order to do a data collection like a surveillance system, we have to indicate how much time does it take to collect the data. They don't ask us how much time it takes, as you said, to rule out that it isn't one of these. And if we put that burden in, it would increase significantly. So it's a really good point, and I'm not sure if we can add it or not, just so they understand that it's not, I mean, it looks huge as it is. I don't know if you've ever gone to the Federal Register and seen the number of hours. It's, you know, it's ridiculous. But we certainly know, as IPs ourselves, what it takes to get the data. And, you know, again, we're really, really appreciative that you're here, both in person and on attending by web streaming, because we know that you're interested and committed and want to do the best you can do. So give yourselves a pat on the back for being here and making the effort daily. One last question,
Yeah.
and then I'll let you go
It's
to
a quick one.
lunch.
I had a question about the upcoming changes for the hips and the knees that are going to be in 2014. And are those the kind of changes that are going to be addressed in ICD-9 coding that we can extract via that resource?
I think the changes will better align with the way the coding is. Now, it'll better align with ICD-9 codings, but bear in mind, we'll have to relook at all of that for the ICD-10s. So I don't know that part yet. But essentially what those changes will be about really putting together the revisions in a better way, or keeping track of those revisions in a better way than we can do it now. The primaries are not a problem. It's those patients that have multiple revisions where we're not actually able, in the way we do it now, to characterize the risk of SSI as well as we would like. So it's the changes are to really better, to get us better data on the hips and the knees, especially those that are revised. Okay?